Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on Yersinia Enterocolitica under the section of infectious diseases. So this is a slide showing the Yersinia Enterocolitica, which is, again, as previously mentioned, not very common in the MRCP exam to be tested on. However, the college is still very much within its right to ask you about these, especially as part of the MRCP Part 2 written exam. So it would be recommended to have a broad understanding of these different histology and microbiology slides so you can have at least an educated guess if this was the case on test day. The epidemiology of Yersinia Enterocolitica is that it is most commonly affecting human infections in Europe, Japan, and North America. The outbreaks have been associated with contaminated pork products, tofu, and untreated water. As for its pathophysiology, it is a gram-negative, rod-shaped, urease-positive bacterium. The routes of transmission include ingestion of the contaminated food, especially undercooked pork, water, or contact with infected animals. It's capable of growing at temperatures as low as 4 degrees Celsius. And the virulence plasmid, or PYV, encodes a type 3 secretion system that injects toxins into the host cells, which will eventually invade the human response. The clinical manifestation, as the name suggests, it very frequently causes enterocolitis or terminal ileitis and eventually can lead into mesenteric lymphadenitis in humans. And it can almost mimic a case of appendicitis in the young adults. It can cause abdominal pain, diarrhea, fever, and sometimes vomiting, which would again explain why it can be sometimes confused with other far more common conditions such as appendicitis. And the complication of this include reactive arthritis, erythema nodosum, and in severe cases can cause bacteremia. If you would like a refresher of either reactive arthritis or erythema nodosum, please click here and here, which will link you directly to our extensive video resources on rheumatology and dermatology, which will be talking in length about these two conditions. The management of this disease is actually usually self-limiting and supportive. Antibiotics, however, may be required in severe or complicated cases. Let's do some questions. A 35-year-old man presents with right lower quadrant abdominal pain, fever, and diarrhea. He is diagnosed with Yersinia Enterocolitica. Considering his symptoms, which of the following is the most appropriate initial management approach for this patient? A. Immediate surgery to remove the affected section of the intestine. B. Oral rehydration therapy and symptomatic treatment. C. Start intravenous antibiotic immediately. D. Administration of antidiarrheal medication to reduce fluid loss. E. Intravenous corticosteroids to reduce intestinal inflammation. So, if you recall, this is a case of a gentleman who is not particularly at risk, as in he's not elderly and he doesn't have any history of immunosuppression. He's presenting with quite classic symptoms of Yersinia Enterocolitica. Recall that the correct management in here would be actually supportive, and there is no indication to start antibiotic in these cases with the current information that you have in front of you. Therefore, the correct option is going to be option B, which is oral rehydration therapy and symptomatic treatment. We have already discussed why option C and option A are not going to be correct. It might be tempting to pick option D as a way to reduce fluid losses. However, don't fall into the trick that you would want to be using antidiarrheal medication in someone who has an infectious diarrhea. Remember, the goal is to actually let the patient have the diarrhea so they can get rid of the toxins that are produced in the intestine, while you are supporting them with intravenous fluid and electrolyte management. The risk of giving somebody like him antidiarrheal medication is that the toxin can get built up in the bowels and it could potentially lead to toxic megacolon, which is a surgical emergency. And option E is completely incorrect. Corticosteroids do not provide any benefits in somebody who have an active infection outside of the context of intensive care unit. Therefore, giving him corticosteroid, you're just dampening his immune response and potentially causing thinning of the intestine and actually worsening the inflammation. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.